in this setting, if giving naloxone actually binds to, endogenous opioid receptors, then it is possible that that binding might actually increase the already depleted catecholamines in this patient. And
Sure.
the addition of giving epinephrine and all that kind of stuff, that might actually help to facilitate the run. All right, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester from the Overrun. This is part 2 of naloxone or NarCAN in out-of-hospital cardiac arrest. So let's get right into this. Last week, we discussed a paper from New Jersey that showed that NarCAN does not improve outcomes. And this week, we have a paper from California that shows that giving naloxone in cardiac arrest does improve outcomes. Again, retrospective cohort study, they gave NarCAN as part of out-of-hospital cardiac arrest. It was associated with greater rates of ROSC, improved survival to discharge, and they used propensity scoring here. Again, given the lack of clinical practice data on the efficacy of naloxone out-of-hospital cardiac arrest, these findings support further evaluation of naloxone. So what's different in this study from last week's? This study had 8,195 patients. The breakdown of the patients is much, much better. Again, retrospective, so they just did a chart review, and they looked at patients over the age of 18 who received non-traumatic cardiac arrest in 3 Northern California counties. So this was done in San Francisco and UC Davis. So this is not Los Angeles, which I think is important for the actual data set. And this is coming from Dylan et al. So, Danny, last week we looked at a paper that said naloxone does not improve outcomes. And this week we have a paper that was written a month earlier than last week's paper that said naloxone does improve outcomes. So when I say we have no idea what we're doing in cardiac arrest, this is what I'm talking about.
You stand by your statement.
I stand by my statement. But super interesting data, right? Because again, in last week's study, we had about 800 patients. In this week's study, we have 8,000 patients. Different system, right? Different response model. So we talked last week about systems and how all that can contribute to it. But here, do we think that maybe that part of the issue was just the sample size? Because one of the greatest things in this paper here, and I'm going to bring it back up on the screen just so everyone can see it, is the number needed to treat in this was 9. So here we have number needed to treat with naloxone was 9 for return of spontaneous circulation and 26 for hospital discharge, which means that in this study, giving naloxone is more effective than most of the treatments we give in the field anyway. So what do we think here, Dan? What are we doing wrong here in New Jersey?
I gotta say, I don't
it's exactly that, right? It's like, is California doing it right again?
No. I don't think anybody's doing it wrong. I don't think anybody's particularly doing it right. I think in this study, they had very promising findings. And I think it has to do with a lot of factors, demographic factors, socioeconomic factors. There's probably a lot response factors, tons of things that we don't see in this study that I'd really like to delve into. It'll be great to talk to some of the authors of the study, just like we did with the New Jersey study. Now, what I like about this study is that the N is a lot higher than the study we looked at last week. And that tends to tell me that we probably have a better group than they did because you get a more heterogeneous group, you see more results. And if it trends a certain way, you have a little bit more reinforcement that this might be on the right track. That being said, it just goes to show that we, as I said last week, we need to be doing tons of research. We need to be doing it across the country to understand better what works and what doesn't in cardiac arrest. As for practice, I'm going to take a look at this, and I kind of think it's a low-risk, high-reward thing. If it fits, I might give naloxone in cardiac arrest.
And I tend to think that's right. And again, any study gets more interesting the more you delve into the data here. So looking at this paper, NarCAN was given in 1,165 cardiac arrest cases, which is 14.2% of the sample size. In New Jersey's paper, it was about 21 to 23%. So there's actually more patients in this study, but less naloxone administration. And again, this was done in Northern California. What's interesting is that this was an 8-year retrospective chart review. So this was 2015 to 2023. Now, what's really interesting is in those type of retrospective studies, you have COVID that kind of fit in the middle there too, right? So given this type of study, how much did the COVID pandemic actually affect these numbers, right? So were patients home more, and thus by being home more, they're closer to an EMS response agency, or were they closer to a hospital in that setting? Did were overdoses higher during that COVID period, which might have led to, better response rates and better outcomes with those patients? Like, again, this is where, all of our fellow neurodivergent people can sit there and be like, but what exactly did we need to know in this data? Which is what I do when I read it.
But isn't this where science gets so cool? Because we have so many conflicting ideas, and coming to a consensus in a group where, hey, there's evidence to both sides. What works, what doesn't work, what's a benefit, what's not. What we haven't done here is, as I said last week, no one has done a big scale randomized controlled trial of what naloxone does in cardiac arrest. And I think these two studies are really good evidence to show that that's what we need. We need a multi-center RCT to say, okay, we're going to randomize this. We are going to give naloxone to this group. We're not going to give it to this group. Nobody's going to know what they're giving or what they're not giving, and we're going to see how it works out. We're screaming for it. We need people to do this.
And just real quick, in last week's study, we talked about the use of Gestalt as well. And in this particular data set of the patients that received naloxone, 59.6% were not thought to be drug related. So we did have some clinical acumen, some thoughts in here. We had younger patients who were presumed to be drug related, patients with non-shockable cardiac rhythms, had higher odds of receiving naloxone. Conversely, older patients and the presence of comorbidities were associated with lower odds of receiving naloxone. So again, building off of that sample set from last week, we still had providers who walked in and said, I think that this patient might have an opiate on board, and that might be contributory to this cardiac arrest. Thus, I'm going to give NarCAN. But that only happened in about 40% of the patients. So this drug was given empirically, and they still had this higher rate of return and this higher resulting outcomes. So again, I think that muddiness, those confounding factors, do really make these data sets interesting. So is it that, again, and we talked about this last week, if we're giving naloxone just arbitrarily as part of unconscious protocol, like we see in this study, is there something that we're missing that we just don't know in this certain cohort where naloxone helps? And it could be something as simple as, it might be that giving an opiate antagonist causes a certain amount of, say, vasodilation downstream, right? There's a lot of really interesting kind of biochemical things that can happen.
It's interesting you say that. It's interesting you say that, because some people have hypothesized that naloxone actually increases catecholamine levels. That by blocking those opioid receptors, we're actually causing almost like GABA and NMDA work, like one's inhibitory, one's excitatory.
Right.
They're saying that might actually happen. So we may not even know what naloxone does in cardiac arrest.
Yeah, that's possible too. And I mean, the actual function of naloxone by preferentially binding to mu receptors, again, and this is without having anything in front of us, we're just spitballing here, but we're happy to hear any data you might be aware of. In this setting, if giving naloxone actually binds to, endogenous opioid receptors, then it is possible that binding might actually increase the already depleted catecholamines in this patient. And the addition of giving epinephrine and all that kind of stuff, that might actually help to facilitate the ROS. We know that patients who have overdosed, typically their biggest problem is hypoxia, right? So from the EMS side, it's more fun, it's more sexy to give a BVM, give someone naloxone and bag them up, and then they wake up, right? That's what we see on television. That's the exciting thing. That's the patient we bring into the hospital and like, look at what I've made for you. I did this and now they're better. You're welcome, right? But how many of those patients in this cardiac arrest are just so catecholamine depleted that now we give them, this naloxone and maybe that turns it around? it's
We
not a
don't
great
know.
hypothesis. I haven't elucidated it on paper, but it's a thought process where there might be something that we're just not seeing or that we're not looking for, right? That phase 4 unknown that we're just not aware of. So it is possible that there's also, this is that fun part of the far right side of the Dunning-Kruger curve, right? Where now we know a lot. We know enough to know that we don't know what the hell we're talking about, right? and that, I think it's important to get to that level
We're
of
in
growth.
the pit of despair.
Exactly. But it's important to get to that level, right? Where if we can say we don't know, then the next step is we're going to try and figure it out. So as discouraging as it is for me to read papers on epinephrine and how, futile giving epinephrine is, it's nice to read papers like this where it's like, okay, listen, getting away from the epinephrine problem, there's treatments out there that might actually improve outcomes that we're really not thinking of. And I don't want it to be a system specific thing where, last week, New Jersey's model has 2 separate responders. This is 3 different counties in California, which might all have different response models, which wasn't really compared, and they didn't really elucidate that in the study. But is it that people in California are closer? Are they more culturally willing to give NarCAN over people in New Jersey, right? And if that's the case, then what do we do to fix that? So I think that there's a lot of variables between these 2 studies that should only lead to us asking more questions.
Yeah, I think that's exactly right. And I think I'm going to try to blow your mind.
I'm ready for it.
What if naloxone does something that we have no idea it does?
No, exactly. Yeah, and that might be another thing too.
I mean, think about it. It's a generic med. We give it for opioid overdoses. We don't really know what it does. We think it does this. We don't know what it does in the stage of cardiac arrest. Could it block endogenous endorphins so that we can increase catecholamine release? We don't know.
Right.
That's what's cool about this.
And that's where it gets exciting.
We've only been doing modern medicine, like not bloodletting, for about 150, 200 years. We literally have only been doing EMS for 50. This is wild. We are on the cutting edge of the frontier.
Yeah, this is like figuring out that leeches don't work. Right?
But they do. But they do.
I do love the idea of sterile medical leeches being grown and being used in a lab setting. I love that someone came up with that idea. But
I mean, it was bananas, right?
Yeah. Well, and again, this might be, as this data comes out, as more and more of this data comes out, it might be that the right way or the better way to treat cardiac arrest might be the empiric usage of naloxone. And it may be, right? And this is the fun, it's fun that we're kind of like paraphrasing Neil deGrasse Tyson now, right? Where it's like, well, it may be that if we do this, then we'll see this. But it may be that giving naloxone empirically improves outcomes in cardiac arrest, right? And if that's the case, we have to study that. Okay.
Yeah.
So we get that studied. If we show that giving naloxone is independently associated with improved outcomes in cardiac arrest, then we really start having to have the question of like, all right, well, what else do we give naloxone for? Because this is starting to kind of follow the same trend that ketamine followed, right? Where with ketamine, we couldn't give it for anything, right? It had that stigma attached to it. And like, oh, well, this is a veterinary drug. It's a recreational drug. And then we started using ketamine, and you and I had conversations a decade ago where now is it possible that there's more settings to give ketamine than there are to not give them, right? Because you've got pain management, it's an anxiolytic, it's a bronchodilator, it does all of these things. So it might be that naloxone kind of fits into that camp too, where this is the intended use for it. We know it works for opiate overdoses, right? That's out. That's, it's so easy to do that they're giving away naloxone at pharmacies so that lay people can do it. And that is terrific. But it might be that from our side, giving NarCAN or giving naloxone to these patients might cause an improved outcome, and we don't really know why. But if we can have a data set that says this actually changes things, then we can give that data to all of the biochemists and all of our friends in white coats and labs who can actually run the molecular data, right? Do PCR analyses and say, okay, well, it would make sense that this causes this, and that's what causes the outcome.
Sure.
We don't know. But again, this is that, we talked about Dunning-Kruger earlier. This is that kind of phase where we have an idea, but it might take a couple years for that idea to come to full elucidation. So something that we tend to talk about a lot in these journal clubs, Danny, is does this change your practice? And I'm interested in your thoughts on these two papers, and then I'll say some dumb stuff, and then we'll get out of here.
Okay. Does this change my practice in cardiac arrest? I'm going to paraphrase Dr. Milne and say it depends. Certainly, if I think that there's somebody that may benefit from naloxone, I'm going to go ahead and give it. I don't know that I'm going to give it empirically to every patient, but I definitely think that it's something that may have a benefit. And I think we should be looking at it. I think we should be doing multi-center randomized controlled trials. This drug is cheap. We basically give it away to people. Let's take a look at it and see what happens.
And I think it would stand to reason that if it's going to be so prevalent, right, among the lay population, it would benefit us to study it in the first place.
Sure.
I don't know that this changes my practice, but I do think it's going to give me pause, right? I think that in cardiac arrest for a while, it feels like at least we kind of got away from the H's and T's in cardiac arrest a little bit. And I think that's more of a function of now data is focused on 20 minutes in and out, boom, done. I do think that, the arrest that you're 5-10 minutes in, right? And you're sort of like, all right, well, what else can we do? Now, and I say that fully accepting that it might be that now I'm giving it too late, right? So I do think there is gestalt that's involved, but as far as practice changing, I think it's something that it's more of this is available in your armamentarium, right?
Sure.
Okay, now we're going through this, and I hate to say that I'm just as complicit and biased as everybody else is, but I am. If I have someone who's in their 70s, I'm probably not thinking they're an opioid overdose. So and that very well may be a mindset that I have to change myself. But let us know what you guys think. Are you giving enough NarCAN? And what kind of research do you want to see on NarCAN? Be sure to follow the Overrun everywhere you see us on all the stuff, Apple Podcasts, Spotify, YouTube. Check out all of our news stories on EMS One. Subscribe down below and check out our website, overrunems.com. We have classes coming to you in 2025, so that will be exciting. For the Overrun, Ed Bowder, Dan Schwester, we will talk to you next week.